We didn't know we had to do trial and error lives first.
Okay. Even old school got to be taught. Okay. But I know now. That's okay.
Come on in, come on in. Healthy hustles in the building. Kima, your hair is adorable. Oh
Girl,
my gosh.
this too much. All these curls is too much.
Look at all the hair.
I'm
Oh
going
my
to wrap it
God.
tonight. No flexi rod tonight. Cause this look how tight these curls are, huh?
Oh my God. Look at all that hair.
Mm-mm. Child. This
Come
is
on
not
in,
getting
y'all. We have a special guest today. Come on in. Ooh, Lord, I've been waiting to have this conversation. Y'all, Aaron Sahale is coming up. Aaron Sahale is coming in the building. Oh, let me let him know. Or does he know? Let's see.
I saw him over on that side. But I couldn't hit the button.
I'm waiting to see him pop up.
Hey, Sheena. Hey, side to side. Hey, Brian.
So apparently, y'all, with the podcast, we have to be live. There's like a trial and error before you can accept guests. I guess they want to make sure that we really want to do this thing.
Right. Girl, they asked me for an age verification. I got to put my age in. I got to scan my face. What?
That's him. Let's see.
Hey, Kelly. Let's get it. Mic check.
Oh my gosh. Aaron Sahale.
I did it. We're here.
Hi.
You made it.
I did make it. I was on the struggle bus, but
Listen, you and I both. You can't imagine what I looked like 15 minutes ago.
I'm feeling my age today with this weather. I'm sitting here all hunched in my chair.
Oh my God, it's freezing. Hello, everybody.
Hey, y'all.
Oh gosh, Aaron, get ready because today is all about you.
Oh yeah.
And is.
How have you been doing?
I'm good.
Oh my goodness, it's so good to see your face. Oh
Thank
my
you.
gosh. Hey, friend.
I even got my little thing. Ask me anything. Doesn't mean I'll know, but you can ask me.
Oh my God. Whoever missed this live, I'm so sorry. Y'all are
Right.
missing out. Y'all are missing out. So what's going on? What's going on with all these titles behind your name? I'm so proud. Let me just say this. I am so freaking proud of you.
Thank you.
So proud.
I just got alphabet soup. That's all. Alphabet soup.
Oh my gosh, I'm so proud of you. So, Kima, oh my God, all that hair is just so gorgeous, girl. Okay, so Aaron, thank you for being here. I know that you are so busy.
Oh no, thank you for having
You are
me.
so busy. Can you introduce yourself and tell everybody who you are, what you do, and especially where to find you, especially your online telehealth as well?
Sure. So my name is Erin. I'm a licensed nurse practitioner. I'm double boarded in family medicine and psychiatry. I also have a concentration in emergency and trauma medicine. So that just means I have 3 master's degrees in all those different specialties. But I sat for boards for the first 2. I see patients all over. So depending on what you're being seen for. So in this situation, which actually you can be seen for both, but let's start with where I'm licensed as a family nurse practitioner, which would allow you to see me for GLP-1s specifically. That's going to be Maryland, DC, Virginia, Pennsylvania, Florida, California, Washington, Texas. I think that's everywhere. I want to say that's everywhere.
And you take insurance, right?
So if you're being seen for mental health, I take a few insurances in Texas, soon to be California as well. The insurance world is very complex. However, I have very competitive cash rates that are approximately 50% of what my colleagues are charging. A new mental health eval, for example, is $175. Now, a GLP consult is $35. That's just the consult, like where we talk and say, make sure that you're a candidate, so on and so forth. That's not the cost of the drugs. That's just for you and I to chit chat and talk. Are you, a good option? Is this a good option for you? It just depends on the service and the state and how we can get you started. But strictly insurance is just mental health services in the state of Texas with a select few carriers.
I need a mental health eval. And I'm serious. I'm serious.
Everybody does. Oh, and there's my husband. My husband's stating.
See him.
Charlie.
Hey,
Pointing out
Charlie.
my states, because sometimes I forget.
So listen, okay. Oh my God, it's just so many things. Kima, go ahead, friend. Because honey, I'll start flying, honey.
So I am like all over. Okay, so let me bring it back. So one for anybody in the chat. Now he's good with PAs. I just want you to know. He's very good with PAs. No, but seriously, so I'm excited, of course, to have you here because I do have a lot of questions as it relates to how these GLP-1s affect people that have diagnosed mental health conditions. Because I've heard people say they experienced anxiety after starting the meds when they didn't have the anxiety before. I'm someone that had anxiety before taking the medication, and I feel pretty chill, after I started taking. So do you kind of see that in your practice, the two relating, or what do you see, I should say?
So there is that, carve out with almost any medication, right, of warning signs and what can and cannot occur. With GLP-1s, we do put on there that you could have new or worsening suicidal ideation and or depression and or anxiety. Now, in terms of mechanism of action of why that's occurring, I don't 100% understand why it would cause that. To be honest, I believe that a lot of that comes from the fear. 100% understand why it would cause that. To be honest, I believe that a lot of that comes from the fear of phobia. I literally just had this conversation, I think it was last night, with a patient who literally passes out. They vasovagal. So basically, they pass out at the site of a needle. The fear of the unknown causes anxiety. The fear of the side effects. Am I going to get sick? Am I going to be nauseous this time? Is it going to work? What are the long-term effects? That spiraling domino effect that people put themselves into, that's really where I see it come into play. Now, most people typically do very well, and they have a lot of resolving symptoms from a lot of various aspects of their health, from their mental health, from their GI tract, from inflammatory things like rheumatoid arthritis, MS, other autoimmune disorders that are inflammation driven, cardio effects. We know that it's cardioprotective now. I've actually seen a lot of the insurers drop Wegovy for weight loss and only have it for cardioprotective, cardiovascular disease purposes, which is absolutely a joke to me. Yes, it works for that very, very well, but that's just silly. So now you have to have a problem with your heart before we can give it to you. So you got to get overweight to then get cardiovascular issues to then get the meds. Yeah, makes a world of sense, right? So I see it resolve a lot more, but I think a lot of the anxiety and the things that come along with that are more self-inflicted than it is literally from the drug in itself. Now, with that said, you have your compound agents, right? So, for example, if you have one that's compounded with B12, which is what a lot of mine are, we can make it without, but B12 can cause anxiety because it can increase the heart rate. And when the heart rate increases, there's that domino effect of anxiety. So if you're already an anxious person and you do a compound that has a stimulant like B12 in it, which a lot of them do and a lot of them don't. Or if you're supplementing with those other things that have a activating component like the B12 and some of the other supplements, that's where insert potential for new or worsening anxiety. Because anxiety starts half the time, 99% of the time actually, with your heart starting to race and you start to get that flutter and you start to feel real nervous, but it starts with the heart. That's why we use drugs like propranolol, which is a beta blocker, just a type of medication that's typically for blood pressure. And what beta blocker does is it actually prevents the heart rate from increasing, thus trying to control anxiety. We use it a lot for public speaking. Like if you're really nervous about stepping up on a stage, that's where we use propranolol. Some people use it for general anxiety. I don't find it effective. More situational, I think, is better. But that's really where I'm seeing it. If anything, I am seeing positive responses, not negative.
Okay.
So, I never thought about putting that two and two together about with the anxious person who takes B12 because B12 is a stimulant. I never put that two and two together.
Yeah.
Because people, people say, I've heard a couple people say, does this medicine make you anxious? And I'm like, no.
No, of course not. What are you talking about?
Right.
But if
But
you
it
have
matters.
B12 in it, yeah, it can. It's supposed to give you energy.
Yep. That's commonly a lot of the issues. That's why, like, people that have anxiety, when we were using phentermine, stimulant, major stimulant, right? People that unrelated to GLP-1s, but another great one that I see because I constantly have this conversation. Wellbutrin, which is used as an anti-smoking and sometimes for weight loss. Wellbutrin is an activating type of antidepressant, so you have to be very cautious when using it in people with anxiety because people that are anxious are already active. So giving them an activating medication could cause worsening anxiety. But we like it for the people that are like, I can't get out of bed in the morning, I can't get motivated, I don't want to do anything. Give them that activating Wellbutrin type medication, and it's going to ideally get them up and going and giving them that boost, that oomph that they need to get going. But flip side, you can worsen anxiety. Same thing with the supplements. If it's an activating supplement, it can worsen anxiety.
Got you. So when it comes to mental health awareness and being on GLP-1 medications, what are some things people can identify within themselves to help them identify that? Because I feel like a lot of people in the community, outside of GLP-1s, they don't know how to identify when they have mental health issues. Like me and Kima was having a conversation the other day, and we were talking about anxiety, depression. We talked about bipolar disorder. We talked about BDD, which is body dysmorphic disorder, and then we also talked about it was one other. Oh, SI. Okay, yeah. And so we were talking about like looking back on our lives as we were educating because we were doing like refreshers with one another, and we were also trying to do a video in a way that the viewers can learn as well as we were doing the refresher for ourselves. So we were both like, dang, I used to do that. Or, I could remember a time where I would be in bed and Kima had said specifically that she would seclude herself. Isolate herself was the word. And I was like, I used to do the same thing, so we were trying to determine whether or not were those stages where we were having depression. And then there was some anxiety situations that were going on. We were trying to decipher if that's, symptoms.
Sure.
So what are some things people can identify within themselves?
So kind of to circle back on part of what you were saying. So a lot of people that suffer from obesity also suffer from depression because we're not going to deny the stigma. People look at you. People make fun of you. People talk about you. You don't feel good about yourself, especially if you're not if you've always been skinny and now you're, obese or overweight. A lot of depression comes with obesity. And depression can also be situational, meaning it just occurs because of a certain situation. It doesn't mean you're going to have it forever. I had this conversation with a gentleman earlier that just because you have depression right now does not mean you're going to stay on medication for the rest of your life. For some people it does, and some people it doesn't. And what you were experiencing, what you both were talking about, was probably a form of low-level depression. As you see, you've lost your weight, and I'm sure your moods have changed. And if they haven't, then maybe there is underlying chronic depression. And, then we can identify that. But if the new and improved you and the, skinnier you has resulted in a positivity and change in your mental status, then we know that it was situational. It was really related to the obesity and the stigma and the complications that come with that. Think about the people that have to buy 2 plane seats. That is a thing. Imagine how depressing that could be, that you have to buy 2 plane seats to be stared at when you're eating in public.
Yes.
Your younger population, kids are mean. Okay, kids are mean. There's just no denying that. Kids can be very vicious individuals without even realizing it sometimes. So a lot of the depression that I see is cause and effect. The obesity is causing the depression. Just like a lot of mental disorders. I had this same individual, talking about PTSD, anxiety, and depression. I said, sometimes we have to figure out the cause and effect here. Is the PTSD causing the depression and the anxiety? And if we control the PTSD, do we control the depression and the anxiety? Or is only one of those left? And then we come down to just 2 bubbles. You have now depression and PTSD, or anxiety and PTSD, but we got rid of one bubble because we're controlling the symptoms of the other one. Just like ADD, same thing. Are you ADD? Are you bipolar? We have to decipher that. We have to break it down, cause and effect. We in healthcare tend to just throw diagnoses on people without really thinking through what is the predominant symptom and what is the predominant cause. And sometimes you don't know right away, and sometimes you can never figure it out, but typically you can. With that said, people probably won't know unless they do a depression screening like your classic PHQ-9 or your GAD-7 for anxiety. Those are just screenings that are issued at your primary care doctor's offices or mental health offices that kind of score based off of how you respond to a set of questions. And those are diagnostic tools, meaning tools that help us diagnose, but they're not always, it's not always a definitive tool. Just because you have this number doesn't mean you have depression. It could mean that you most likely do. Same with the anxiety tools and all the other ones we use. We use a lot in mental health. But the point is that, we have to really sit down and kind of look at your symptoms. And as you start these medications, as you both have kind of indicated, you start to see some things changing about yourself that make you reflect, oh, maybe I didn't realize I was so self-isolated. I was so, quiet or so nervous to go out to dinner because, this, that, and the other. Buffets are anybody that likes food likes a buffet. But what does an overweight person do? They think about their plate the entire time, and they're looking around. Are they watching me? Why are they snickering? Are they snickering about me? That paranoia. Now, that paranoia doesn't mean you have schizophrenia. This is a situation that, unfortunately, the reality is people are mean, children are mean, but people as a whole can be pretty vicious and mean to the obese community. Or overweight community. It doesn't even have to be obesity. It can just be overweight. If you're not fitting that specific, picture for that individual, then they'll look down upon you. They'll automatically judge you. I have this conversation with patients all the time. Not everybody overeats. Obesity isn't because you overeat. Being overweight isn't because you overeat. Most of my patients say, I barely eat, but look at me. And I'm like, well, let's start talking about insulin resistance and metabolic disorder and depression. Depression alone can cause you to be overweight and obese because you're sad. And then what people do is they reward themselves with food because it makes them feel good. Why? Because it goes to the reward center. The same reward center that alcohol goes to, that heroin goes to, that nicotine goes to, it's a reward center. We've got one. Anything that makes you feel good is going to your reward center. So it can be tough in the beginning if you're not self-aware. And a lot of people are very good about being self-aware and can identify themselves and know and identify change, but many don't because they don't know any different. This is the only thing they know, especially those that have been overweight since they were children and that it's, progressed into adulthood.
Yeah.
Yeah.
It's
So,
so.
Aaron, I have also
Go ahead, sister.
I have some questions that I saw in the chat. So Shay asked, how do you feel? What are your thoughts on prescribing other peptides with GLP-1s?
So I haven't gotten into the peptide craze. I think that there is a lot of hype and placebo effect, but there is also some truth depending on the specific peptides. I've really just focused my practice on the GLP-1 and some of the other ones depending, on the individual. Like I've added metformin, I've added stimulants for some patients. It can be very, very helpful. But some of the other peptides have been proven to be beneficial to help with weight loss, but it's just not something that I chose to dive into.
Gotcha.
So, okay, go ahead, Kima. I'm sorry.
I'm asking this question then because Summer asked this. She said, do you think that maybe depression can be misdiagnosed as PCOS?
Yeah, depression can be misdiagnosed for many of things. PCOS, ADD, and ADHD. It's now called ADHD, but I'm still old school and I think ADD. But ADHD is a great example, just like the PCOS. For example, with ADHD can mimic depressive symptoms and cause depressive symptoms. So somebody might be being treated for both, when really, if you just treat the ADHD, the depressive symptoms can be resolved. And vice versa, don't get me wrong. Same with PCOS, because some of the things that come along with that, right? The obesity, the infertility, those alone, two things. Tell a woman that she has fertility issues and you have just crippled them.
Yeah.
It's damaging.
Yes.
That is just like a woman that has to have a mastectomy. If you
Yes.
cut a woman's breasts off, that is a piece of them. That is their identity. So is fertility. The ability to get pregnant is a woman's identity. Not everyone wants to be pregnant, but to know that they can't changes them in ways that it is just unimaginable. So absolutely. The side effects that come from PCOS absolutely can be, I guess, misdiagnosed as depression, but it's not that it's misdiagnosed, it's cause and effect again. It's that whole cause and effect.
So I definitely can identify with what you were saying about, the fertility thing, because I had my daughter through a fertility specialist. And I went years thinking that I would not be able to experience motherhood. And it's definitely damaging. You think that your body is built to create life, and then when it's challenged, that's some depression for your ass. And then I was blessed to have a baby, and then circle back to the mastectomy. Then I had to have a mastectomy. I lived without my breast for 9 months.
Mm-hmm.
So that's a very real situation. And it is about identity. Even
that.
Yeah. I still have a hard time sometimes, with my reconstruction, you know what I mean? But it's like, you learn to live with it, but yeah, that is definitely some depression for your ass.
I think that it's common. I think a lot of times we don't think about cause and effect when it comes to certain things. Like, for example, a mastectomy. Yes, it's saving me from breast cancer, or it's a lifesaver type of procedure. But did anybody counsel them that the effects of having your breasts removed will do to your mental health?
Yeah.
Same with plastic surgery, and I have witnessed this firsthand from a good friend of mine. They had plastic surgery, enhancing surgery. They changed not the breasts, but in the face. And they said, so I understand body dysmorphia, not only as a provider, but as an individual. I said, what do you mean? They said, I don't recognize myself in the mirror. Like I literally I cannot identify myself in the mirror. I don't know who I'm looking at. I'm like, well, shit, I never thought about that.
Yeah.
Because you alter the shape of the nose, you alter the shape of the chin, you raise the cheek. If you alter anything that all you've known is that, makes complete sense. I was like, I never even thought about that. Insert body dysmorphia for patients on GLP-1s.
Yes.
Especially those that were in the morbid obesity category and now are in the extremely skinny category. Mm-hmm. That's a complete change.
Yeah.
Is it a change in terms of their weight? But think about the excess skin. That's a whole new thing. Before it was taken up by adipose or fat. Mm-hmm. So now you have all this skin. So this is going to cause an obsession of, oh my gosh, I can't with this skin. Like I want it off. I want it off. I want it off. Or I'm going to go work out and I'm going to get muscles and it's going to fill this. Body dysmorphia, part of it is preoccupation with parts of your body. And there's actually one specific, an identifier, as we call it, for just muscles, either being undertoned or overtoned. But the point is that, yes, that we can cause some of these things with the GLP-1s and the weight loss community. I got totally off track. We were talking about how identity and certain things, change. Obesity is an identity for some people.
Yeah.
Look at all of this, the creators on here that have their fan base because they intentionally mock themselves by eating to the point of nearly vomiting.
Yeah.
And people absolutely, for lack of a better term, eat it up. I think, to me, I am like, why would you subject yourself to that? Mm-hmm. But that is their coping mechanism. It's their comfort zone. Food makes them happy. So they're happy while they're doing it. And they're getting attention for the first time because, let's be honest, people that are generally overweight don't get the attention that they typically would get if they were smaller or that they want. They might get attention, but it might be unwanted attention. I mean, how many people can say that, there's been, that high school jock or that high school cheerleader that they were so into, but they had acne, so they knew they wouldn't like them, or they were overweight, or they were scrawny, or they weren't on this, that, and the other. So we know what rejection feels like. So sometimes, we seek attention anywhere we can get it, and to basically mock yourself and embarrass yourself to get attention, that's a level of that's an issue. That's an issue in itself.
So I want to say one thing before I forget. When you were talking about the loose skin, I had wrote on here loose skin because I definitely wanted to talk about that. Whenever I am talking with people, especially people who are just starting their journey, I always say, or I try to say, try to envision your body and what your body is going to look like when you get toward your goal. Mm-hmm. And also, and ask yourself, is this something that I will be able to live with? Is this something that I will be able to mentally see myself? Because I can remember in my 30s, in my 30s, I lost 60 pounds on phentermine and my breast deflated. Like I had no adipose in my breast at all. So my breast was like flat, they were, it just was a mess. And I was so, I ain't gonna say disgusted with myself, but I was like, damn, if I would have known my body was gonna do this, I wouldn't have lost weight like this. And so I gained 30 pounds back just because I didn't like the way my breasts look then. So what are some things that people can mentally do to prepare themselves? Because it's like, you don't want to be overweight. You know that you need to get that under control to prevent exacerbation of other issues that can be contributed to the inflammation that sits with obesity. And at the same time, once I get to my goal, now it's like another thing. So it's like I went from being obese and being depressed to now I have all this loose skin and I'm depressed. So it's like, what do they do? Like, what, and we can talk about surgical procedures and stuff like that, but some people just don't have the money for that. You know what I mean? So it's like, it's just so hard to decide what to do. What am I going to be happy with? Because it's almost like I'm damned if I do and I'm damned if I don't, because I'm going to be up and down heavy and I'm going to be up and down with the weight loss, because now I have this thing that has replaced the fat. Now it's skin.
So first and foremost, definitely, it's going to sound like a cliche, but it kind of helps you get started. You need to do a pros and cons. What are the pros of me losing weight? What are the potential cons? And how do I feel about these cons? The pros, we'll always be happy with the pros, but we're really looking at the cons. And which am I finding that I'm going to have more of a problem with? All the cons? Or am I more happy about all the pros? But what really needs to occur, and what frustrates me about the weight loss provider community, is that these are conversations that providers should be having before they hand out medications or be available to discuss when the patient has that problem. Because, for example, these are not new problems. It's new because of the GLP-1 craze that we now have. But think about when we had the Roux-en-Y surgery. That's basically where they reroute your entire GI tract. Yes. When we started with the gastric sleeve, what happened to those patients? All of these same problems existed. It just wasn't publicized like it is now with the GLP-1s because of the large community that has been created and the fact that social media is different now than it was then, and so on and so forth. But the point is, my mother had a Roux-en-Y surgery, lost a ton of weight, has an excessive skin. She embraced it and was happy that her diabetes was reversed, that she was able to walk more comfortably, that, function, manage, and pick up her patients, because she's a nurse as well, but she does pediatrics, so she's got to be able to maneuver these kids. There were so many benefits. And for the longest time, she had no problem with the skin because, like you said, insurance doesn't cover that. They'll get you skinny. They ain't going to help you with the other stuff. But on top of the skin component, think about the people that have excessive skin in the
He froze.
Overlapping skin. Well, that's a breeding ground for infection.
Yeah.
So there's that complication. Did I warn you that about that, or educate you? Make sure you powder those areas to keep them dry. Make sure you're lifting up the skin to clean under it. Just like teaching your young little boy, if you have a boy, that you got to clean the foreskin. Same concept here, people. Skin over skin. But no, they're just giving them the surgeries, following up. Okay, you're cleared. You lost your weight. Don't do this. Don't do that. Have a great day. Oh, you want your skin cut off? Meet with the surgeon. Plastic surgery. Probably won't get covered. Hey, we just toss them to the side. Same thing with the GLP-1 community. People are writing these drugs, but they're not educating, or they're educating incorrectly. I see that one a lot. I'll see people come in on these just on, for example, semaglutide for 0.25 the starting dose. And I'm like, how long have you been on that? 5 months. Why? Why? Well, they just told me, to just keep, refilling. It's like they're not educating. They're just, you show up. What are you on? 0.25, and they write it for you and collect your money. There's more to it. This is a passion. I think that I've made that very clear from the get-go, that it is a passion of mine, and that is why I did not really jump into the GLP-1 social media craze, because I just really was focusing on my patients. I mean, I did some. You and I did a lot together at one point, but I just felt like it was getting out of hand. I was getting frustrated with all these people that are just pushing, and I'm like, it's great to push it. It's great to help the people. We're here for the people, right? But what about all the other stuff that we don't really talk about? But that's not going to get them their views. People want to hear about, how am I going to get skinny? How do I get the skinny drug? How do I get on the meds? How do I? That's what they want to know. They don't want to hear about the negatives. Well, reality is the negatives exist.
Right.
You need to prepare people for it. Maybe not right off the bat, because then we're going to create that fear. Well, maybe I don't want to lose weight. Well, just know approach and tactic is key. If due to the amount of weight you have to lose, there most likely will be excess skin due to the fact that, it's, your size. It's going to happen. There are surgical options that are going to cost you, out of pocket. So you might want to start preparing for that. Maybe create a fund, or, think about, how you're going to handle that, and prepare them for that, because it's not talked about. And we just need to do better as a community and as providers. We just need to do better.
Yeah.
Just at the end of the day.
I can say, I think since I've been on this platform, well, since I admitted to people that I was a nurse, because originally when I started on this platform, I didn't tell anybody I was a nurse. But I've always pushed people to reach out to behavioral health, whatever behavioral health component that they have with their commercial insurance plan, because when I educate my patients every day on new diagnoses and medications, 9 times out of 10, they tell me they have been prescribed a medication, they've been given this new diagnosis, they've been sent out the office, and no one provided education to them. New insulin prescription, and they were not told how to use a glucometer, what their parameters were. But I do think the mental health piece is super important in the beginning. I do remember there was a time where insurance companies were requiring a mental health check.
For weight loss, right?
Correct. I don't know what it is now, but I remember there was a time when that happened. But of course, if you said answer the questions appropriately and say it like that, it was only a one-time, deal with the nutritionist, a one-time deal with the therapist, and then they kind of write the script and you go on about your business. But I push there a lot because it takes a lot to prepare yourself mentally to go from a bigger body to a smaller body, to get rid of clothes that you adore, that you can bless somebody else with, but because they are your things, you have a hard time parting ways with that. I think I've done 5 hauls, and my mom said, "Are you giving away everything? You might need it." No, because in my mind, I ain't going back. So everybody can get whatever they need out this house, But I think that people need to tap into that mental health piece in every aspect of life, because it is hard managing your mindset with the journey that you have told yourself you're going to embark on, because sometimes those don't match. You know what I mean? We say we want to be, my goal weight was 180 pounds. Okay, now I'm weighing 150 something. I was not ready. I was not ready. I was looking at myself in the mirror, and I can still find things that I don't like. But that's my reality. So I'm still trying to figure out, am I going to gain 10 pounds over here? What am I going to do? But I've had to reach out to my provider and a therapist, because I need to calm my spirit and figure out what my care plan, my mental health care plan will be. And I don't think a lot of people really think about that as they really think about care plans.
No, and they really don't. And I think that, yes, so from the first part, so yes, if you're still getting the gastric surgeries, most of the time you need to do clearance, because they actually were teaching us how to do clearance in a clinical that I did. And what's even more horrifying about that experience was we're basically told, well, the quicker you get the note and the approval over to the surgeon, the more referrals they're going to give you for them. So are we doing the assessment, or are you just telling me to write the letter and move on? Right. Because how many people in here know that with gastric surgery, alcoholism is very common? Mostly, yep. Alcoholism is a massive complication for gastric sleeve and Roux-en-Y patients. Very, very common. Major issue for that community. With that comes the things that we've talked about. You're going to tell them about the skin? Are you going to tell them that it's not covered by your insurance 9 times out of 10? No. They're just going to get them approved and move on. People ask me when I went into mental health, oh, are you going to give up your weight loss stuff? No. Actually, if anything, I think mental health should be doing weight loss. I was like, luckily, I'm double boarded, so I know family medicine, so I know what to look for from that aspect, and I know, and I do mental health, so no. But I think that we should pull them from some of these places, because what we're also doing is we're creating or worsening body dysmorphia. Do you know that I will not sign somebody up that wants to lose 10 pounds? Nope. Now, if you have a history of obesity, that's a whole different story. If you lost 150 pounds and you're coming to me and because, that's a whole different story. But the vanity aspect, I do not give into it. Absolutely not. No. We're creating problems. Those are the same people that are addicted to plastic surgery, so on and so forth. There's nothing wrong with wanting to look nice, and there's nothing wrong for wanting certain things about you changed. That part's okay. When it becomes obsessive or in excess is when it's a problem. But these providers don't care. They want their coins. A lot of them. That's not to say all. It's not an inclusive statement. It's just a very common issue. So it's very frustrating on my end.
Yeah, and so for people who don't know how to identify that, when me and Kima were doing our research, one of the identifiers was if you are constantly looking for validation from other people, if you're constantly looking in the mirror, constantly trying to readjust something, constantly trying to tweak something, and it's like that's all you think about, that's when it's an issue. Because I think people don't know how to identify things, because there's nothing wrong, like you said, there's nothing wrong with wanting to change something to boost your confidence, because it's a confidence booster. But it you have to tread lightly when it's something that you are obsessed about. Like it's even when you change that, it's going to be something else, and then you change that, it's going to be something else. That's when it is the problem.
It's that when you become preoccupied, and think of it as people that are overeaters. That preoccupation with food, that food noise that we turned off with GLP-1s, same concept. Just replace food noise with your body. That's when it's a problem. And how do I know it's a problem? Sometimes you won't be able to identify it, because you might think, well, this is just normal behavior. I'm just trying to make this better and that better and this better. That's when maybe if you question it, you should bring it up with your provider, because then they're going to start asking you the more in-depth questions that you're not necessarily going to think to ask yourself. But preoccupation, like being preoccupied with your body and or a certain part of your body, is really a good indicator, where you constantly, like you said, are looking in the mirror, constantly looking at a specific part of your body in the mirror. Like, I'm so preoccupied, I got to get this stomach flat, I got to get this stomach flat. Well, yes, there might be a healthy component to, you want to get it flat, so that's going to give you the drive to go to the gym and do it. Or is it becoming unsafe? Like those people that are obsessed with muscles and started injecting saline into their arms to enlarge them. Okay, that's when we've reached a problem, body dysmorphia. When we will get told no, but we go and find somebody that tells us yes, that's questionable behavior. I know somebody that was told no by their primary for plastic surgery because they said, no, you're not ready. You need to lose more, because if you get the surgery and lose more, you're going to basically reverse what you've done. Well, they went and found a surgeon that would do it anyway. Well, to each their own, I guess, at that point. So it's when you start to get risky and you're willing to risk certain things, it's questionable behavior.
So speaking of risk, first of all, I want you to, Abby had put a great question in the chat. She says, can we define excessive?
Excessive is when you become it's predominantly what you think about. Just think about, use food noise as your example, because that was thrown around in the GLP-1 community a lot, because we've talked about it, right? And it is a majority of what you think about. One thing that we tell people, do not weigh yourself every day. Weighing yourself every day is excessive. We fluctuate. We already know that, right? You've talked about it millions of times. We fluctuate every day. From water to stool to all of the things in your body that are occurring, you fluctuate every day. But excess is weighing yourself every day. Excess is constantly looking at a piece of your body to see if it's changed. Because I don't mean it rudely, but I guess just lack of a better term because my brain's tired. We should know that our stomach isn't going to change from yesterday to today overnight.
Yeah.
You know, we know that, but you're looking every day for that change. That's excessive. I tell my patients, weigh yourself once a week. That's okay. I'm okay with that. Once a week is good. Gives you an idea of what the week looked like. You know, in the beginning, we do it every day, right? Because we're so excited. We're on the GLP-1 journey and we want to see those pounds move. Okay, yeah, that's cool. Do it, you know, make it excess. A great excess, because we see it with OCD, is the Apple Watch. Can I tell y'all how much I hate the Apple Watch? I'm sorry, anybody. I love Apple products, but I hate the Apple Watch. That is one of the worst things you can give somebody with OCD. My heart rate is 101. My heart rate is 98. My heart rate. And I've had a patient sit there and watch it the entire time during the assessment. I have literally told patients, throw it away.
Yeah.
This is too much. You're looking at it too much. If you check your heart rate every day, okay, that's cool. I'm cool with that. Just check in once. Okay, my average tonight was 98 beats per minute. That's okay. Every 5 minutes, not okay.
Yeah.
When it is becoming either ritual, habitual, or it is affecting your ability to do day-to-day things, that's when we identify things as a problem. You know, people ask me, well, how do I know it's a problem? When it affects your day-to-day. If it's affecting your day-to-day, if it's becoming like habitual, or you feel like you have to do it, you know, obsessive, that's when it definitely is a problem. Just like you should be able to go, I can walk past the scale and not have to step on it. But if you walk past the scale and you have to step on it, that's a problem.
Yeah.
Yeah, it took me a long time to get to that point, because I was definitely one of those people that not only weighed every day, honey, I weighed on 3 different scales every day. So it took me almost 2 years to get to a place where I could walk by the scale, look at it, and keep on going.
Yeah.
You know, but I'm being honest. It took literally 2 years to get to that place where I'm like, I don't have to wait. It's okay, Kim. You don't have to get on there.
I used to weigh myself every day as well. I mean, we all were there, I think, in the beginning.
Right.
Especially in the beginning of the GLP-1 journeys, because we didn't understand it. We didn't know what was really going to happen to our bodies. Like, it was so new from the weight loss aspect that, you know, we were our own worst enemy in that aspect. But like you said, you were able to get past it, and probably some mental health coaching would have been good. I tell every single patient, and I do believe, and I live by this statement, I really do, everyone needs a therapist. Everyone. A non-biased individual to talk to. Because they don't know your ins and outs. They don't know your best friend. So you can have that open dialogue, say whatever you want. They're not going to think any different of you. Their literal job is to sit and listen without judgment. And they can really help identify things. And sometimes hearing things from a therapist makes a world of difference than from a friend. I have been told the exact same sentence from a friend, then by a therapist, and that's when it clicked. I was like, oh shit, well, I guess if you're saying it, it must be true. Because you take what your friends or your family or whomever says with a grain of salt. But when a complete stranger says the exact same thing that you've been hearing, it hits differently. So therapy is a great component. Therapists, I think, they don't get enough credit. Just because they can't write you for meds does not mean they don't understand mental health. People come to me and go, I thought you were a therapist. I'm like, well, technically, I can do cognitive behavioral therapy. I said, but I think you should see a therapist. Well, why? Because they've got better tools in their handbag than I do, because behavior was their focus. I learned about behavior, but I didn't study it solely. I don't know every tip and trick and all that. Can I get you through a regular set? Sure. I always tell them, but you should go see somebody else. Go see somebody else. I'm really good for writing the drugs or telling you do or don't need the drugs, but a therapist is going to be key. And sometimes my patients just come to talk, and that's completely different. If you just need an outlet, and because your insurance, I'm covered by your insurance and you're coming to talk to me and that's all we do, okay, cool, I'm okay with that. That's okay. But point is, everyone should have a therapist. That's a really good starting point, because we have to think about the stigma behind mental health. Going to see a psychiatrist, a psychiatric nurse practitioner, there's stigma there. So people are less likely to want to do it. I'm not crazy. There's nothing wrong with me. Okay, well, you want to go talk to a therapist? Everyone likes the therapist term. Like, oh yeah, I'm okay with that. My wife recommended that. My husband made a comment about that. Okay, it's not as much stigma. There's stigma, but just not as much. So, those are great starting points as well, because the therapist will also identify, hey, love working with you, but you probably need to go see someone. They make suggestive diagnoses. They don't make those diagnoses, but they're suggesting. I had somebody come to me, well, the therapist thought I might be bipolar and thought I should probably come see somebody about that. Lo and behold, they were bipolar, and I treated them. But the point is, they're very smart people. They went through a lot of schooling, just like you and I did.
So Aaron, can you tell, since we almost have 200 people in the chat, can you tell everybody how to find your practice again?
Absolutely. So if you're looking for, and a little confusing, and I'm so sorry. If you're looking for mental health services, I have launched and rebranded, and that is going to be synergymind.health. Synergymind.health is my mental health aspect. Will I pick up weight loss patients from that aspect? Absolutely. But if you're looking for weight loss information, specifically all the nitty gritty and pricing and this, that, and the other, you can go to my qmmcare.com website. And on there is pricing, a bunch of information, my 2 cents. That website still exists and will exist. But if you're looking strictly for that, you can go to that website. If you're looking for mental health and weight loss, but you're unsure of what direction you need to go, that's going to be my synergymind.health website. Regardless of what website you go to, each has the ability to book with me. So if you forget one over the other, you still will find me.
Aaron, spell Synergy Mind for the chat, so my sister can put it in there for you.
Sure. It's Synergy, SYNERGY, mind, MIND, health, HELTH.
Okay.
So yes, there's no .com. .health is actually what it is.
Okay. Y'all got it? So for the 174 people who are in the chat, thank you so much, side to side. Can you also put the states that he is that Okay. I think Kima dropped down to come back. I don't know what happened. Hold on. She'll be back. Oh, here we go. Sorry, y'all.
I was like, where did everybody go?
I had some fiber optics placed at the house. And I've been having a hard time ever since.
Oh, no.
Okay.
So it's not working out in your benefit?
So for the 100, y'all, thank you for staying with us through the technical difficulties. For the 178 people who are in the chat, you guys make sure you are following the Health and Hustle podcast down here on the right. And then make sure you are following Aaron Sahale, you guys. Thank you guys for being here. Thank you, Charlie. That's what I was looking for. These are the states that Aaron practices in, you guys. He does mental health, and he also does weight loss therapy, you guys. And he does insurance, right, Aaron? Am I?
Insurance for mental health patients in Texas, only a select few plans right now. More are coming. I'm just waiting for the credentialing process. Um, but it's going to be in Texas, it'll be Aetna, Cigna, United, and some of the other plans that are splits from those companies. But I add those to my website as I get them.
Okay. So we don't want, I know you had a long day, and we don't want to take up too much more of your time, but there is one other thing on my agenda that I wanted you to talk to the live about. And that is when you were speaking to people who are in the weight loss community, um, who start to doing things that are maybe unsafe. And when you said that, the first thing that popped in my mind was the split dosing. We've been talking a lot about split dosing lately,
Sure.
and I've been educating the community, trying to educate the community on um, you know, that first of all is not appropriate. If your doctor isn't splitting your dose, then it's not appropriate. And then there's some bad things that can happen. We had this big conversation Monday night. So what is your take on patients, specifically in the GLP-1 community, that are practicing with split dosing their medicines without their providers being aware?
And when you are referring to split dosing, are you meaning taking like half on Monday and the other half on Thursday?
Yeah.
Okay. So I utilize split dosing for my patients that are extremely sensitive to GLP-1s, meaning even the lowest dose and they get super sick. So for those, I've had a couple that ended up in the hospital. There was nothing ended up being wrong with them, but they symptomatically got so sick, right? So those are the ones that I split dose with. It has to be determined by you and your provider because it is case by case, and we have to determine if it's appropriate for you and tell you the potential consequences of split dosing. Because a lot of you are split dosing, and guess what? You're reusing the same needle. Now tell a nurse you're stabbing yourself with the same needle and tell me what they're going to tell you. So we have to talk about that. I always ask, do you have extra insulin needles? I said, and if you don't and you're going to do it, you are at risk for infection. So scrub the hell out of that needle. Because a lot of times you get your meds, like compounds, sent to you. Well, they're not sending you extra syringes, and unless you go and buy them or you work in healthcare where you can grab one, how are you going to safely deliver that second dose with the same syringe? So that is huge, because now you're gonna let's give ourselves MRSA, right? Like a localized cellulitis. Wonderful. No, those are things that you need to talk to your provider about, because most people, the layman individuals that don't know the fact that MRSA lives on their skin and that we have staph on our skin, don't probably realize that if you're gonna do it, you better clean the hell out of your skin and clean the hell out of your needle. Because it's truly not safe. And you dull the needle. It's going to hurt going in a second time. These are like the little things that you got to talk about. Risk versus benefit. And is it appropriate for you?
Right.
But split dosing, it should be done by the provider, or discussed with the provider. But I do it. Don't get me wrong. There is a time and place for it. Absolutely. It's patient specific.
So that was definitely basically what I was educating the community about. I specifically said that there are different reasons why your clinicians will split doses for you, and it's to make you build a better tolerance for it, to decrease side effects. There was another adjust to a dose escalation, maintain daily function, manage your hunger better. But that's all under the umbrella of your clinician. Your clinician is evaluating that. Your clinician has the clinical experience to be able to split your dose for you. You don't have that. You don't know that. And so I was saying that there's some side effects to patients who do the split dosing, and it is exactly what you said, like, risk for infection, risk for loss of efficacy of their meds.
Mhm. Mhm.
So we were basically talking about that. So I just wanted to get your intake on that so that it can come from a clinician
Oh,
rather
absolutely.
than
Yeah, no. I think that, in all of your information, I mean, I've heard you educate, and I always say, she knows more than I do because you're an excellent educator. And all those things are absolutely right. Split dosing, just, it really is so patient dependent.
Mhm.
I think that some people are trying to extend their medications, but I use it also for, like you brought it up, and I didn't think about it until you said it, the people that have the extreme, almost like rebound hunger towards injection day and go ravenous, those patients, possibly somebody a candidate, but also how long you've been on the med before I split
Yeah.
dosing.
Yeah.
What else are you experiencing? I smell food. What else are you experiencing? There's a lot of factors that go into these decisions, and I
Mhm.
think a common misconception in healthcare is that we can rapidly make those decisions where they look somewhat to patients, so they think, oh, well, I mean, they said yes, that's cool. Well, you don't realize the 50 things that went through my head before I spit out the yes and how fast I went through it.
Mhm.
It's like,
Mhm.
there's a different literal brain processing power in nurses and providers that the laymen don't have. You're just not trained to do that.
Mhm.
And I think that's a common thing. People just see, oh, it's so easy. You just, they say yes. They just want to get your money. They just want an appointment. No, that's really not it. We
Mhm.
actually are trained. We've gone through a lot of schooling, and we think differently.
Mhm.
So, there's that component, but I think a lot of patients think they can manage their own healthcare themselves or they
Yeah.
know best. And sometimes, and that to that point, there's nothing wrong with being an advocate. You should be an advocate. You should question your provider and you should push back. I tell my patients all the time, I do not mind if you visit Dr. Google. Tell me what Dr. Google tells you. Sometimes it's accurate. I
Mhm.
said, there's nothing wrong with looking and researching and asking. It's when you take the Dr. Google and make the decisions on your own without
Mhm.
consulting.
Right.
Mhm.
Yeah.
Because that is where it's a game changer, where people don't know the nuances of certain things that we know because we were trained that way that Dr. Google leaves out.
Mhm.
Why do you think ChatGPT and all these things always end? But talk with your healthcare professional.
Mhm.
You're only seeing a snippet of the information.
Mhm. Yeah.
Whereas when we went through school, we were given that fire hydrant of information.
Mhm.
So it's just, you got to keep those little nuances in there.
Yeah. Now, in the GLP-1 community defense, I have heard a lot of people who say that they do split dose. Now, I don't know if they are dealing with their providers or not. They say they do it because in the middle, like you were speaking to, in the middle of their week, they lose the suppression. And so I try to educate them about, you know, first of all, that mindset shift that has to happen where you stop thinking that you're taking a weight loss medicine and you understand that the meds are made to change you metabolically. And even if you're not feeling suppression, something is still happening metabolically. And it's like they forget. I feel like they forget. So I try to understand, their reasoning, which is, they're so focused on the suppression, they forget about the insulin, the insulin sensitivity that's happening, that how it's controlling, keeping that liver from pushing out that glucose, so it's like they don't think, like you're saying, they don't think clinically like a nurse or a provider, are thinking. They're just thinking from their level of understanding. And most times it's the appetite suppression that they're holding on to or feeding into when they're doing the unsafe things like split dosing.
Right.
And that's why
And
it's so important to go back to your provider. So I speak to people, it's okay to feel however you feel, but take that specific information to your provider so they can help you understand while you A can or B cannot split the dose. You can feel however, but have that real talk conversation with your provider so they can help you. It's okay, because if you don't know, you just don't know.
Right.
And I think a huge part, and this is going to chap a lot of asses when I say this, I think that people tend to forget that you have to take some accountability and responsibility when you are doing weight loss. And just because you are hungry on Wednesday does not mean the medication's not doing its job. I'm sorry that you're hungry on Wednesday. You're going to have to put in some effort to not eat everything in front of you because you're hungry. However, with that said, I understand that control can be tough for some people. Again, therapy is key here. Talking to your provider is key, but we have to remember that you have to take some accountability. People think I'm taking this drug and the drug is supposed to do everything and I'm just supposed to sit here and get skinny. Well, here to tell you that's not the case. Another thing, I'm hungry midweek. What's your protein intake? 80% of the time that you're not losing weight, it's your diet and it's your protein. Well, I don't really eat that much. Okay, again, that's because you're putting your body into starvation mode, which means it's going to hold on to every little bit that you do eat. And I hear people, yeah, the drug just doesn't work. And I'm like, well, that is the case for some. Don't get me wrong. I don't deny that fact. But really, what's your diet look like? If you're eating, I'm only eating a little bit a day, I'm going to ask you how many calories is in that little bit a day. If you're really not losing weight, I want to know how many calories then. I want you to count your calories. Are you eating 3,000 calories in a day? Because even though you're only eating 10 bites that equal 3,000 calories, well, it's only 10 bites, well, it was 3,000 calories.
Right.
You're going to lose weight. Because the truth of the matter is, while all of the additional benefits that I know that you have spoken to until you're blue in the face occur, the number one takeaway about weight loss is, the truth of the matter is, the only way weight loss happens is caloric deficit. Calorie deficit, less consumption than your body needs. That's how weight loss works. We have proven this time and time again. GLP-1s help you achieve that and achieve it in a way that is different than trying to self-diet and restrict, amongst all of the other things that it does that when you were just calorie, restricting and you didn't lose weight. But you got to remember that that is part of it too. So there's just, again, this is that educational component that people are lacking. They're just handed a GLP-1 and set off into the world. So.
Kima, did you have any other things that you wanted to talk about, y'all? Let's drop our questions in the chat, and we'll let Aaron answer 10 minutes because we don't want to take up too much of his time, y'all. He did work today, I'm sure.
I still have work to do.
Oh yeah. So let me see. Something that I hear people talk about. To the people who say, I've been on these medicines for 3 months and I've only lost 10 pounds.
That's a common one. I love that one. Again, 80% of the time, it's the protein because they're starving their bodies because they think I've been on the meds for 3 months. I should have lost all this weight. I'm never eating. That's what I hear. I don't eat. Okay, well, if you're not eating, how do you expect your body to lose weight? You got to feed it to lose weight. And they look at you like, what? It's like your body needs nutrients and it needs to be able to function safely. And your body is naturally going to go into, starvation mode and protect itself, and thus you don't lose weight. Protein is key. On top of that, I ask them, what is your dosing schedule? What is your caloric intake? And there are some people that just don't lose weight on certain meds. There are some that fail the therapy. In my opinion, a lot of times it's behaviors, or they were undiagnosed diabetics and they didn't know it. Because GLP-1s will correct your A1C and your diabetes first before the weight loss will occur. And that is a big conversation I have with my diabetics. And I'm like, it's going to do the job that it traditionally was created to do, which is lower that A1C. And then you should start to see some of the weight loss. You'll see some of it during that process. But that A1C is going to get normalized before you see the big weight loss most of the time.
Mm-hmm.
Because we got to remember, GLP-1s were not created initially for weight loss. They were created for your diabetes. Weight loss, what a lot of people don't realize, was a side effect.
Right.
And it wasn't the typical side effect of just a pound or two, as we all obviously know. It was massive amounts of weight. And then that's when the study started looking into, oh, well, it helps with inflammation. It helps with obesity. It helps with this and it helps with that. We designed GLP-1s for A1C control.
Mm-hmm.
So remember that. So I tell people, you have to get a good history on them.
Mm-hmm.
And compliance, people will tell you that they've been compliant. People also lie because they don't want to hear the truth.
Yeah.
If you don't take the meds the way they're prescribed, if you haven't been titrated correctly, when I get a new patient and they tell me, well, I did it for 3 months in the past, what were your doses?
Mm-hmm.
What were you on? Also, where are you getting your product?
Mm-hmm.
Just because somebody wrote you for a GLP-1 does not mean that the product they gave you, its potency and all of that, is actually accurate. Okay, the fact of the matter is, these companies, any company, anybody doing it, they're the big ones, the ones that are just so massive. They're the ones that aren't doing all that extra education, all that extra stuff. They want your money. We all want your money, but they want your money. So they're going to hand you out a product, and they're going to get the product as cheap as they possibly can. So there is questionable efficacy and potency of that product. So I bring that up too when I take on a new patient or talking to somebody who's been on them. That is a big part of it, because I have taken on patients and given them the exact same dose that they were on from other companies. And they're like, I don't know what you gave me, but that made me super sick. Like, that stuff was super strong. And I'm like, it wasn't that it was strong. It was just an accurate dose.
Yeah.
Because I have trust in where I get my product.
Mm-hmm.
Also, injection site and all that. We've talked about that, and leg, thigh versus upper arm versus stomach. So there's a lot of factors. I go into it, and if I still hear, they don't work for me, well, I can only give you the information that I can provide you, and you do what you want with it.
Mm-hmm.
I definitely don't argue it. I tell them, try again, or there's really nothing else I can say, But I just do a lot of education. I probe, just like a mental health patient. I'm trying to peel back that onion to find that one little thing that's going to tell me why it might have been happening.
Mm-hmm. So for someone who is just starting, I see, let me see, which person? Katie says, where should we start if we are starting at the beginning of the journey? I think she may want to know I don't really want to put words in her mouth, but she says, where should we start if we're going to begin our journey?
In terms of?
Yeah.
Like, where should you start as a whole? Like, how should you start the whole journey?
Somebody is asking. I don't really understand your question, baby. But if you are talking about GLP-1s, they're different GLP-1 medications. You have to be a little bit more specific, baby, because I don't even know how to answer that. There's another person in the chat that says, is it okay to take MJ10 every day? Because my doctor's friend told me.
I responded.
Oh, okay.
That's not for us. That's between that person she's referring to and their provider. I've never heard of such, but that ain't got nothing to do with any of us on this platform.
Right.
Yeah.
Let's see.
Remember, when you're asking your questions, we're limited in what we're going to say, and we're not going to go against your provider unless you're a patient of ours, and we're not going to give medical advice.
Right.
Give medical advice to a specific individual. We might talk in generalization, but I will never. No provider is ever going to ask a direct question that is direct medical advice.
Yeah. And for the young lady that was asking, where do I start? My sister put in the chat, you can start with a goal and a plan in mind. So that's really good advice. If that's what you mean, friend. Marquita is asking if you can explain insulin resistance. That's a great question.
Yeah, so, it's funny that you asked that, and it's not a short answer, but what I will tell you is if you go to Health and Hustle's podcast, there was a physician on there I just saw it before I came on, that discusses insulin resistance. And I think it was well done. I listened to the whole thing. Listen to that because it's not a short answer. And quite frankly, I'm hungry. I haven't eaten today. So
Yes.
I don't feel like getting into it. But basically, it's a metabolic disorder. That is the dirty, long, dirty, short answer to that. It's a metabolic disorder. But go to Health and Hustle's podcast, and there's a physician on there that speaks about insulin resistance.
Dr. Cook. Yes.
That's right.
Okay. So we are going to wrap things up. Our sign man is getting tired. Our NP needs to go and eat. Erin, thank you so much for
Oh,
coming
it's my
on and
pleasure.
talking with us. I appreciate you so much. We are going to post this live to the Health and Hustle podcast site, and we're going to put all of your information and your links in the description with the states that you service. So I appreciate you so much. This is an amazing conversation.
Oh, I agree. It was great seeing all of you again. It's been so long, too long, but
Yes.
let's do it again soon.
Yes.
I don't mind if there's specific topics that if you want to create a list of specific things you want me to go over, maybe in depth,
Yes.
where I can prepare more material versus just off the top of my head, I'd be happy to. You're very welcome to those. Saying thank you. It truly is my pleasure. I like talking, obviously. Also, I went into mental health. All I do is talk now. But yeah, if you want me to focus on things that you want me to research to bring back, I'd be more than happy. There's no such thing as too much information.
Yes. I'll get back with you. I will
Spreadsheet.
get back with
Of course.
you. Thank
Well,
you
have
so
a
much.
wonderful evening, everyone. I am going to jump off. I smell food. I'm hungry.
Tell Charlie
So-
I said thank you so much for sharing your time with us, honey, because I know.
I will let you know. My
Okay.
pleasure. Have a wonderful evening. Stay warm for the Texans that don't know how to handle this weather. It's cold here. All right. Have a good night, guys.
Bye.
Alrighty. Bye-bye.
Now, why are you embarrassing us?
Fine, man.
What a great conversation. Oh my God. That was good.
Keisha, you know I was trying to go to our Discord to find them questions, right?
Listen. Yeah, I think that we did good. I think that it was a good discussion.
Yes.
Nurse Rock said it's snowing where she is.
And she in North Carolina. Oh my God.
Y'all, we got up to 50.6K likes in the first Health and Hustle podcast live. Now listen, y'all. We had no idea that we had to do a few lives on other people's platform before we can go live ourselves. So the next live will be hosted by Kima, and I'll be on the Health and Hustle podcast until we're able to do it solely from the site, with the site being the host. So that's what happened there. For those of you who are wondering, y'all, but Erin is my nurse practitioner. Erin is the person who takes care of me on the insurance side of my journey, and also y'all other things. Y'all, he's a nurse practitioner. Again, he's a mental health NP as well. I'm definitely going to be making an appointment with him on the mental health side. Just to take care of some things, personally. Y'all know I got a lot of stuff going on. I'm a bedside nurse still. I work in a highly volatile
Stressful situation.
Service line. Y'all know I do emergency and outpatient, and then I'm a full-time content creator. I'm an educator. We got the podcast. We got a lot of dates coming up for podcast
Mm-hmm.
Y'all listen, we got a lot of calendar dates coming up, and a lot of, it can get tough. Um, so it's nothing wrong with asking for help when you need help and identifying when you need help and getting it. There's nothing wrong with that. I think we all need to be more vocal about it, and find the community of people that will support you. And I thought that it would be Kima and I thought that it would be very important for us to bring someone on to talk about mental health, because we all are having so many mental health changes during our weight loss journey. And I don't know if we talk about it or not, but I think it is a conversation that we needed to have.
Mm-hmm. Absolutely. You know, I see my mama. Y'all say hey to the preacher's wife. That's my mama. Baby, you see how mild I get when my mama come in the chat, baby. Ooh.
Y'all
Yes.
make sure y'all following the preacher's wife, honey, because she finna be posting.
Yes. And don't be sending my mama nothing crazy now. Take her slow. Take her slow. Mm-mm. But yes, it definitely was a great conversation tonight, because I think a lot of people just don't really think about mental health, how it affects diagnosis, how it affects weight loss or weight gain or body dysmorphia. I just really don't think people, really think about it. I mean, when I said I stop, I look in the mirror. When Aaron said being obsessive, I look in the mirror every day, several times, every time I go to the restroom. And you know what I do? Pull up this extra skin to see what it'll look like if it wasn't there. I do
Mm-hmm.
that all the time, just
Mm-hmm.
to get in my mind what will I look like without it, you know?
Yeah.
So, but it was nice
Yeah.
for sure. He will be back because I know we have plenty of questions. I just
Oh
couldn't
yeah.
pull them all
Oh
up.
yeah. And y'all can see he has the it's just something about him that makes him just so relatable. From the very beginning, Aaron takes care a lot of my family members, like my sister, me, my best friend, Kima. He's taking care of a lot of us, y'all, in our GLP-1 journeys. And I appreciate him for going the extra mile, and coming on and doing some education. Again, y'all, he does take some insurances. I'll get that information from him. I know I have Aetna. CVS Caremark is my PBM. He did do a prior authorization for me and my daughter. As a matter of fact, he did get them approved. He got Kima's approved as well. My best friend's approved as well. So, I always tell y'all in the GLP-1 community that if this is something that you want to do, always look into your insurance company, because as Kima reminds y'all, getting the medicine and being able to afford the medicine is one of the key components to the best patient outcome. So if you can get your insurance company to help you pay for it, why not? You just have to find someone who is passionate enough to help you go through those difficult PAs and do the best that they can in those situations. And remember, not all PAs get approved, but it would behoove you to get behind someone who is going to take your best interest at heart, and that's not just thinking about your money. So, oh yeah, and my sister said holla at her because she does prior authorizations. Y'all know that's what she do for a living, so she can help coach you with verbiage. Let me see, can we bring her up for a moment so she can speak on that
Yeah.
for a moment?
Hit the button, Summer.
Oh Lord.
Is she
Oh,
here?
Lovable says I'm dealing with that now. She's dealing with prior authorization. So Lovable, if you need
Good
just a little bit
morning,
more
evening,
understanding.
noon.
Hey baby, if you
Hey,
have
Summer.
some questions, you can make sure y'all are following my sister and go into her DM, y'all. She will find the time to talk to y'all. Go ahead, sis.
What I'm doing?
We're talking about prior authorizations.
Okay, so prior authorizations can be tricky. They're getting trickier by the month. I ain't even gonna say the next renewal point, but by the month. Some of the news, if they haven't already heard, we know Victoza got a generic now. Also in the liraglutide family, Saxenda is FDA approved for PCOS girlies.
Can we get Saxenda though? You know, Saxenda was hard to get.
Saxenda is liraglutide if you break it down. So if you can't get Saxenda, try to get Victoza or Trulicity, you know, and normally those are like tried and fails. Also be
Oh,
mindful.
explain that, sister. I'm sorry. Explain that. What does that mean?
When it come down to try like the basics, when it come down to you guys want to use your insurance, you want your diagnosis to match what the medication is. Now, even though a lot of this stuff is FDA approved, it does not necessarily mean that your insurance is going to cover it. So you pretty much gotta use synonyms. Some policies I wouldn't recommend obesity. I would use something like BMI. The ones that are, I will put insulin resistance on there, but I will also follow it up with if you have high cholesterol, high blood pressure, if you have any type of kidney, like add something onto that. Just don't leave insulin resistance and PCOS and pre-diabetes on the table by itself. Use all diagnoses. The more, the better. We'll weed out, and when I say we, clinical reviewers will weed out what we need. Most
And we're talking about diagnoses that you have actually been diagnosed with, y'all, not just trying to make it look good, because some clinical reviewers will ask for documentation. So this
and
is
when
not falsifying records, y'all. We're talking about things that you have been diagnosed with. Just don't forget to include those things. Go ahead, sister.
and
Sorry.
when we talk about documentation, the documentation is, I don't care if you're 45 now, but a lot of us would have started at 16 or 17 when we went through our hormonal period, birth control. And birth control will be the start of us building insulin resistance and having our hormones. And so somewhere in that time when you were 19, 20 or whatever, you tried metformin. You need to, when you go to your current PCP endocrinologist, you need to let them know your history from the past that you tried metformin. That's normally, we need to see it. Patient such and such and such and such tried metformin. It didn't work. I'm allergic. You can't take it because of your high blood pressure. All that needs to be mentioned on the prior authorization. Your last recent clinic notes normally would suffice. You want to have your height, your weight, your BMI. If you have blood work, put your blood work in there because we use all of that to help get the medication approved. Trial and fails. Metformin is always ground zero, less invasive. It's not just for diabetes. It is also an endocrine medicine. Then when it comes to injection, Victoza, Trulicity. Who I'm forgetting? Victoza, Trulicity. I'm starting to see Ozempic. They put those three in the category together, and then as trial and fail, and then Wegovy starting to be isolated. And what I mean isolated, there's a criteria for when you using a GLP-1 for weight management, and then there's a criteria if you're using that GLP-1 for cardiology comorbidities. So it's split between the two. That's why I say put it all on there. Hyperlipidemia, hypercholesterol. I don't care if you stump your toe because of whatever the case may be. Put it all on there. If you have one of those doctors who do not like to do prior authorizations, which is most of the doctors, go old fashioned route, go online, print that paper out, do not sign the bottom, but fill in that information, bring it to your doctor's office, let them attach the note, let them fax it over. If you don't know how, if you're not tech savvy, you can always call your insurance company 7 o'clock, 8 o'clock at night, 11 o'clock at night. Somebody gonna be there. Member services, they can print it, they can email it to you, or walk you through how to print it yourself. Don't be scared to utilize that stuff because it's there. I heard that you guys mentioned about behavior health modifications. They are asking for that, and when they mean behavior health modifications, it depends on what you're taking it for. Weight management, they want to see that you plan on doing a dietitian, an assessment that you're doing at least 30-minute type of some type of physical activity. Um, you're talking to people, and that's normally for 18 and younger. But when y'all look on y'all medical side and in y'all insurance, they have little programs to where you can just talk to people for free.
Mm-hmm.
So don't just focus all on your pharmacy part. Look at your medical part too, because your medical part can help y'all with your pharmacy part. When it comes to the ones who are type 1 or type 2, get your CGMs, your continuous glucose monitor. Some of them are free. Some of them the medical will pay for it. Some of y'all might have over the counter benefits and don't realize y'all have over the counter benefits and can use to get it. Some CGMs are not over the counter, but most are. It depends, because Walmart is more friendlier than I say the other two, Corner of Happy and Healthy, and the other one. But for the most part, it if you want to get healthy and you need that piece of paper, try it. And if that piece of paper don't work and you're tired, you can always come to Compound too. But try your insurance.
Hold on, I got distracted by Elise saying I'm having a meltdown to have a honey bun. Friend,
Eat it. And I'm gonna tell you, eat it. If you and the main reason why I tell you eat it in moderation, but feed that craving, because you might bite that honey bun and you might not even want that honey bun, that whole honey bun after. Don't ignore your cravings. Do your cravings in moderation. Don't eat the whole honey bun, but just bite it and then just throw the other one in the microwave so you don't see it.
so listen, Darium has a great question as well. Did you see Darium's question?
No, because I was
I put it in
checking.
the chat. Is the one about the labs?
Mm-hmm.
I
Okay.
typed it out so people can screenshot it.
Okay. Oh, there it is. The health and hustle. Come on, health and hustle.
When it comes to
Yes,
labs, you
friend.
guys, when it
Through.
when it when it comes to labs, you guys, women with postmenopause, premenopause, y'all go every year to the we get 2 annual visits. Most insurances pay for 2 annual visits. One to see a GYN and one to see a PCP. They can get your labs done. You can get your labs done twice in 6 months. Men, y'all should be going annually. If you have high cholesterol, if you have heart issues, you can get that done every 3 to 6 months. If you have an SHA or FHA, guess what? A1C, which is a 3-month collective average, you can get that over the counter and use your FHA or HSA to get that done so you can see that. If you don't have insurance, there's standalone labs. You can go to Quest, you can go to labs that have those packages for people. A simple blood test, a CBC, a CMP, and I know it sounds a lot, but Google it. And normally you would need those results every 3 to 6 months if you don't have a provider.
So have you been seeing that on when you're doing the prior authorizations? Is that some criteria that is that a part of some people's criteria?
Yes.
Mm-hmm.
So basically, if you're initially starting, um, we just need some type of documentation, pretty much showing, the your last clinic note visit, and we'll normally approve you for 6 months because you're starting. And then once your 6 months is up, you're gonna need a renewal. Take updated doctor's note, blood work, which would be an A1C if you're diabetic or something. Also mention that you're doing well on the medication. You're just basically giving an update. And then once you get the update for your next, is normally filled for 12 months.
Mm-hmm.
And the reason why that is basically not because the insurance don't want you with your money. It's checkpoints to make sure that you're healthy and not being overly medicated, and the doctor is doing what they're supposed to do on their end.
Mm-hmm.
But I see every day it's either Wegovy, Sextina, Victoza, Freestyle Light, Libre 1, 2, 3. There's another something something. That's all I do
Golly.
all day, and I pretty much do 4 states. I do South Carolina, I do Florida, I do Louisiana, I do West Coast.
So have you been approving? That's what the hell we want to know.
Yeah, I approve. If it makes sense, I approve. And the main reason, if it makes sense, I approve. And the approval process is even easy if it's in front of me and I could prove it, because when we get audited, it's always the same thing that I would do with the people in the chat. Like, why? If you tell me your doctor denied you, my first initial will be why. And the normally reason why 80% of them getting denied, they forgot your date of birth. They done put, let's just say, Keisha Smith on there, and we got 900 Keisha Smith, and I don't know which Keisha Smith it is. So guess what? I'm sending it back, and it's going to be denied. Your doctor will fill out everything, and guess what? Won't even put their name on there. So I don't have no doctor's name, no doctor's first name, no NPI to find a doctor. You know what's going to happen? I'm going to deny it. So that's why I say don't let that first denial kick you down or make you mad. Of course, the doctor's not going to tell you they made that mistake, but if you call your insurance company on a good day later that evening, they can tell you. I always say you get a denial, try again. You get a second denial, then work on your appeal. And while you're working on your appeal, get the compound. And the reason why I say I can get the compound, because an appeal can take up to 30 to 60 days to hear something back. So that's why I be like, don't just get denied and automatically appeal. Find out why you got your first denial in the first place. Fix that. Try again. Once you get two strikes, then let your third be a appeal. Get the compound.
Now, have you been seeing on criterias from the insurance companies where they're asking patients to be on 2 weight loss programs? Because that's what my criteria is now.
Yes. Even my
Why?
insurance, even my insurance say that. Part of that is because it's not the wave, but it's the influx of people now knowing there's other medications coming into play. So it's like a double-edged sword. I want you to get healthy. You're saying you're getting healthy, but some insurance companies, some states pretty much feel that this is still a diabetes medication. And if you having all these other issues, like you say, you need to go try the other route and see if the other route go help, and let this injection be your last result.
But we don't want that. We want the injections. As first, we want the first responder to be the injectables.
And as funny as that may sound, if a doctor is really caring for the patient and gun ho and tell us that, all we're gonna do is, and that's the purpose of a peer-to-peer. You can only say so much on paper, but if me and you over here talking and be like, hey, I want chemo on this medication because chemo went to this, and this, all that don't count. It's not good for her, and the FDA said this. I'm prescribing it like this. She's on a plan. She on this. That don't work for her. This is what I want and feel the best option. And when you sit down in a peer-to-peer, it makes so much sense than reading on a paper, because basically paper ain't nothing but a big old text message thread anyway. So you can get lost in the sauce.
Yeah.
But all they got to do is tell us. They could tell us that on paper. That's why they have any other comments or additional rationale sitting at the bottom that you want to add to. But
Yeah.
they don't. It sucks that you have to be the doctor, the medical assistant, the insurance person, and the advocate these days. But I mean, it all takes nothing but 5 minutes, no matter who do it.
So, in your experience with working with prior authorizations in the GLP-1 space, do you feel personally that these insurance companies just don't want to pay? Because that's what we feel. We feel like they just don't want to pay and that they're creating difficult criterias to exhaust us, almost making it impossible to pass. Like, for example, with my criteria, I feel like, why the hell do you want me to see two weight loss? Why do you want me to be in two weight loss programs? I feel like that's excessive. And it's almost like you trying to it's almost it kind of makes me feel like you trying to make it difficult. You trying to make me work for these damn boxes. You trying to exhaust me.
Which it could be true, because everything is state by state case. Because Texas, we can have the same insurance, and Texas law says this is what we want, because there's a whole board, believe it or not, a whole formulary board for each state or whatever, and they sit down and they discuss that. And Texas might want you to do it, but over here in Louisiana, they tell us, nah, we don't care about that. She went on one. Like, why? So, yeah, I think that is excessive. But I also feel 20% excessive, but 80%, the main reason why y'all not getting these medications, because half is the doctors are not putting forth their best effort, which educating these staff, because it's not the doctors that be filling it out, it's the medical assistants. So they do it half wrong, and they don't read and they don't pay attention, because it's really simple. I deny most of the time because they don't send a clinic note, or they don't send a diagnosis over. Or when it's time for you to get a refill, the only renewal, it really asks criteria after you went through all that work. It'd be like, all we want to know is it how what the patient say.
Mhm.
And you don't even tell me patient is responding well to therapy. She's going to continue another 6 months with a possible increase. Cool. Approve. But you just sending me, just fill it out, and you tell me nothing. I don't know I don't know what you're doing. And then another step on top of that is not just that we look at your prior authorization and your doctor's note, we also look at your pharmacy claim. So if you claim you've been on here for 6 months, and I check the past 3 months and I don't see nothing,
Oh, that's a good one.
I don't like you on, but you the last time I seen you take something was 9 months ago for 2.5, and your doctor telling you you fighting for 10 milligrams. What happened between two? Like, what happened? And you don't. I don't have no documentation, and I don't have no record. And we use that pharmacy claim as another way, just in case your doctor forget to do tried and fail. So I can go back to see, like, well, yeah, she did this, and she's following, and she was on metformin. Oh, look, side effect, metformin, allergic. Like,
Okay,
instant.
so
Ouch.
so two things, because Joni, I see your question, friend. But before we get into that, I wanted to say not too much on our doctors, because this is not a. I don't want anyone to be mistaken and think that we are bashing doctors' offices who fill out PAs. A lot of I just want to understanding to be made. A lot of doctors' offices, y'all don't have the manpower to do PAs. So I don't know whose responsibility that is. I don't know if it's their responsibility. I don't know if insurance, the way the way the office is getting paid, because y'all, there's a lot of stuff that go on
Everybody.
behind the scenes when it comes to who they can hire and how much staff they can have in the office to fill out their PAs, y'all. It's deep, y'all. So a lot of patients, y'all may think that y'all doctors don't want to do y'all PAs for you, but a lot of them don't have the manpower. Yes.
Every I and because I worked 10 hours at a doctor's office, and I leave those 10 hours at a doctor's office to go work at a pharmacy for another 8 hours. That is everybody in between those two, and being from my standpoint, everybody is dropping the ball. And that's the number one excuse. But you have to make time, because guess what? Your doctors, whether your doctors or the staff is qualified or whatever, they get a certain percentage from your insurance. That's why those time slots was like, for a established patient, you get 15 minutes. For a new patient, you get 45 minutes. That's why those blocks are in there. And while they're talking, they have the capability to be typing and doing all that stuff while they're talking to you. Then on the pharmacy end, just like you say, the doctors are short in, so are the pharmacies, because the pharmacy are also giving blood pressure checks, A1C checks, answering the phone, answering the drive-through, taking messages, and doing the same thing too. And they literally be with 3 people. Versus where doctors, they have the power to, yeah, the office don't open at 8 till 8:30, but there's someone there till 8 o'clock. Yeah, the office closed at 5, but there's someone there at 7. And chances are you have a front office assistant, that's the one that check you in, and there's a back office assistant, that's the one that check you out, and then there's the one in the middle of triage, and that's what they do during downtime. So it's like, no, I'm not bashing doctors, because there's a lot. I feel that
No, I didn't say that you were bashing doctors. I just wanted there to be an understanding.
No, I'm letting them know too. I'm not bashing, but I believe it's a lot of semi gatekeeping, and I put that on the law and the insurance company, because if the doctor's office did know what the insurance sides know, I think they would be able to do something better.
Yeah, and if the insurance companies will pay the doctors on time, because that happens a lot. They don't get their payouts from the insurance companies.
It don't happen overnight.
So Joni was asking, if you have sleep apnea and hypertension, are you more likely to get approved? Do you see that? Do you see those cases?
Yeah. But it's basically depend on, like I said with Wegovy, it'd be something obesity due to high blood pressure. It's like, your ICD-10 to have something attached to it. It wouldn't just be high blood pressure. It'd be high blood pressure due to intensity, high BMI, or whatever. So it's not like it's just obesity by itself. It'd be coded with something like high blood pressure or whatever.
Yeah. And then Sister Lisa says, I work on the insurance end for CVS, and she says we have to chase these doctors down to get PAs done, which I believe that that's a reality.
There's a heavy hitter, and I don't want to say no names, but that retail use to give to pharmacy as an automated system. And it gives them the key, and it tells the doctor that the PA needed, and if you go to this system, the system will be A-OK. But this particular system that the pharmacies use to notify the doctor is not friendly, because we don't, and when I say me, us clinical reviewers, we don't have access to that system. The only person that have access.
If I could think about the name of that system, I would tell y'all, but it's
Cover My Meds. It's Cover My Meds.
Okay, yeah, Cover My Meds. Cover My Meds.
It's not friendly, because the only 2 people can access that system: the people that work at Cover My Meds and the doctor's office who set up an account with Cover My Meds. And that's generic. That's generic prior authorization that populates a basic cover letter. So Walgreens, I put in your information, need a PA, I'm gonna submit using Cover My Meds or whatever, and it's gonna say, oh, use CVS Caremark, but they're not gonna fax it. They don't know nothing after that. Don't nobody check the system. What they would do is eventually call, and when I say they, people at Cover My Meds, they will call the insurance to see if the doctor ever followed up on the medication and did their part.
Tasha said that's how we send the PAs, through Cover My Meds. Yeah.
I just want
that's why people getting denied.
The person that was talking about the sleep apnea and Medicare and the medication. When you're talking about sleep apnea, you need to be able to, the doctor needs to provide a rationale between how you having sleep apnea affects your cardiovascular system. Because what happens if you stop breathing? And that's
Mm-hmm.
what needs to be documented somewhere along the way. I was just working with a physician with another patient, something very similar to that. And if you have sleep apnea, talk about the machine and the settings on the machine. Like all of that matters. And if you're using your machine on a regular basis as ordered and you're still having problems, those little things that you might not think are important needs to be documented somewhere.
It's easy, simple as this. Because everybody use some type of my chart or something like that. Your doctor has the capability of just going to that part of your chart and just printing out your breathing records and submitting it along with your recent clinic note, your sleep apnea note from your machine, and the diagnosis that you have sleep apnea due to obesity. And guess what's going to happen? You go get an approval because you have all that documentation saying that, oh, we approve because they come back and check why you approve this, because the patient has sleep apnea, because of obesity, and then this is the medication is FDA approved, and here are the notes that says A, B, C, and D. Like, okay, it makes sense, and they go about their business.
Miss Thickness says, but they won't. You have to. So Miss Thickness, you know what? You're right. Some of them won't do it. That's why we are here to educate you on how to. They probably won't even think to do it, friend. That's why we are here to educate you on what needs to happen so that you can have that discussion with your doctor. And if they won't do it, you need to find somebody that would and I that will. And I know that seems like, why should I? Because I listen, baby, I promise you, I feel like this. Why should I have to go to the extent that I need to go to? And you work for me, like I'm paying you to do this. Like I truly feel like that.
Because some
But,
of these new nurses,
hold on, sister. Hold on. But the reality of it is, in clinics, when doctors are in clinics, they have so many freaking patients coming in and out. For I promise you, they don't have the time to do it. They don't have the time to do it. So it's like, and it's unfortunate that they don't have the time to do it, or they don't have the manpower, or they, for whatever reason it is, it's unfortunate. But if it's like that, that's when you need to learn how to print out your PAs, learn how to fill them out, and bring them to the doctor's office and tell them what you need to be attached, because sometimes that PA is so important that this is like something that you need to do in person. And when they have all the paperwork together, let them know, can I see it before you send it, so that you can look over it, because you're going to look over it with intent. You're going to take the time to make sure everything is there. Whereas they're all over the place, which clinic, I'm telling you, I've been in clinic. Girl, it's like, it's crazy. It's crazy. Clinics can be crazy. So even though we don't want to do it, but I promise you, if that's something that I had to do, and thankfully Aaron has done the work for me on my end, and I haven't had to do that. But I promise you, I feel like this time I will. With all of these criterias that they're giving me to pass
make
my
them do it
PA,
in
I
the
feel
room.
like,
Make
huh?
them do it. It's like I hate that word because everybody's short staffed. There is no excuse on being short staffed. No excuse, because even as you being a charge nurse, if you short staffed, you got to get up off your tail and do what you got to do. With us, if we short staff, we got to stay a little longer and approve a little longer, or approve a little earlier, and do what we got to do. With the doctor's offices,
But the
y'all
patient suffers. The
y'all
patient
the
suffers.
patient suffers all the way around, but that's why you got into this business, to do what you have to do. If I'm at, because ground zero starts with the doctor, and while I'm in the room, and we all know that doctor sits there and do that assessment, start when you get on the door. They already know what you're here for. And
Mhm.
because we've been in this GLP-1 game that kicked up for about 3 years now, they not no rookie to knowing when a PA is needed, some idea of when something is needed. So while I'm talking to you, everybody talks via Teams or via Skype or via whatever. While I'm triaging you, I'm doing this and do the med list, because one thing, when you get checked in the room at clinic, they go over your med list. They ask you why you here. They have an idea of you. You have to multitask. So yeah, you might be short staffed and you don't want to do it and you ain't got time. It could get done. There is no such thing as I don't see. You are all that matters to me when you book your appointment at 8:30. I don't
Listen,
see.
sister, I hear everything what you're saying, and what you're saying is right. But the reality is, they're not doing it because they don't have time. That's the reality. That's the reality.
Yeah,
I want to go back
that's
to
that's why
Miss
I
Rhonda.
left.
Miss Rhonda said she has sleep apnea, and her first step is the CPAP. It's 1035 out of pocket. She can't afford it. Miss Rhonda, go back to your insurance company and ask your case manager, honey, to put out a referral to find out what resources are available in your area. There are so many nonprofits and different organizations that help cover meds and DME equipment in your area, but you will not know because those resources are not just readily available and posted all over the place. But if you ask your case manager, I am sure you can find one that will help you cover that cost.
And that's what I was going to ask you too. Ask her too. Like when it comes down to the sleep apnea, the nebulizer machine, they automatically think you can pick that up. Some pharmacy benefits do pay that. But guess what? Your medical benefit also will pay that and take up for that. That's why I keep telling y'all, don't forget about your medical and those little benefits because they work hand in hand. That is a supply, not a medicine. So you're not going to get that. So yeah, if you go to the pharmacy, is that no? Or you might can go to a pharmacy, which may be a mom or pop or something attached to like a orthopedic shop or where you get like wheelchairs or whatever. I don't know what you call it. They know how to build medical to get that. So it can all depends on where you go to. But don't sleep on your medical part. And then when it comes to that price, that might not be the price of the machine. I'm not sure, but make sure that's not your deductible that you have to meet as well.
Mm-hmm.
But don't sleep on y'all medical. Don't sleep.
Durable medical equipment. Mm-hmm. Okay. Thank you, sister. I appreciate your time.
Yeah. But feel free to DM me on medical and pharmacy. I can help y'all. We could get them PA done. I don't even.
Thank you.
I
I'll
won't.
be DMing you.
Yeah, let me sign off. Let me sign. Love you, Kima.
Hi,
Good night.
So good.
Yes.
Okay, so how y'all feel? How do y'all feel in the chat? Do y'all see where the Health and Hustle podcast is taking the community? We want you guys to have clinical insight on y'all's journey, and not just in the GLP-1 space. We also want y'all to have clinical insight in all of your comorbidities. So this is why we tell y'all have to make sure you guys are DMing us or emailing us to let us know what type of clinicians y'all want on the platform so that they can come and ask these difficult questions that are needed to be answered by clinicians who have time, who make the time to spend with us to answer those questions for us. So tonight we talked about mental health. We talked about mental health as it applies to the weight loss journey. And I think that it was very, very productive. So I hope you all were in attendance, but no worries. If you were not, we will be uploading this to the Health and Hustle podcast where you can do the playback, especially to get Aaron's information, y'all. He is an amazing nurse practitioner, y'all. He has been taking care of me and my family for a couple of years now, and not just for insurance, for GLP-1 insurance. I've seen him on many occasions, and now I'm so happy that he is under the umbrella of mental health now. Cause baby,
Mm-hmm.
I'm gonna make sure I'm straight, mentally, physically, and spiritually, y'all. It's all important. It's all important. So, what say you, Nurse Kima?
I have one thing I want to say. And then if there are any men in the chat, I know Darian was here earlier. I saw him because we talked heavily
Roger's
about
here. My husband's
GLP.
here.
and GLP-1s and just overall women's health. But I don't want you all to think we don't think about you, because I was listening to, I don't even know his real name, Bound Mound, sharing his journey about prostate cancer, and I learned something from him. There are 5 disorders that, if you have these 5, okay, then it's a very high risk for you to have prostate cancer. So I want to just share those 5 metabolic disorders. So for any women in the chat want to share with your husbands, to make sure they get this PSA test done, because it's blood work now. It's not like it used to be. It's blood work. So that's high blood pressure, type 2 diabetes, elevated cholesterol, obesity, and insulin resistance. Okay.
Exposes you to get prostate cancer?
Yep.
Wow.
Puts you at high risk.
I didn't know that.
I didn't either.
Sam again, sister.
High blood pressure, type 2 diabetes, insulin resistant, chronic obesity, and elevated cholesterol.
Oh, Doc Rock says higher risk category. Mm-hmm. Doc Rock, do you want to come up and say something? Do you mind, Kima?
No.
Let me see, because I don't know if she at work.
I think she off. I be trying to know everybody's schedule. I think she off.
Doc Rock.
We have to save our men, honey.
Honey, I need mine. My daddy, my brother, my husband, my cousins. Also, those cause erectile dysfunction, so that's a sign.
Doc Rock.
Hey, ladies. Hey, everybody.
Hey, Rock, how are you?
I'm good, girl. Trying to listen. We got snow, so my grandbaby and my son came over, and I'm listening to y'all just typing away. Hi.
Hey. What say you, Doc Rock?
Listen, y'all, let me tell you what. If somebody is in this chat tonight and not following the Health and Hustle and Kima and Nurse Keisha, I don't know why. It's been so many subjects that y'all touched on tonight that everybody needs to talk about. Everybody just needs to talk. It needs to be up front and center, and to be able to have some educated voices to lead these conversations is what this community needs. Because it's so frustrating now to flip through and to see so many so-called gurus. And I'm just have to talk about it because it's been a thing lately. It's so many gurus out here that have no credentialing at all. And they're telling people to do all the things. And y'all got to be careful. Mm-hmm. I just want y'all to pay attention to what's being said and who's telling you this and what kind of background this person might have. Just be careful. But I do want to commend y'all for bringing up a few subjects that are taboo that we don't talk about enough. The whole how we look, how we see ourselves in the mirror. And I had talked to Kima earlier today, and I was talking to her about, so many of us, we have a number that we put in our mind when we get ready to go on a weight loss journey, right? And we have this number in our mind, but sometimes we're looking at that number, what it was and how we looked when that number was when we were in our 20s. And that number in your 40s and your 50s may not give you the same look. You know what I mean? For me, I know that's what happened with me, because I've always had, no matter how small I was, I always had a full face, right? I always had like a baby face. And I was telling Kima, I've been self-conscious lately. Quiet, boo-boo, wait. I was telling Kima lately, especially since I went under my goal weight, like that little extra 10, 15 pounds made my face, for me, feel hollowed and longer. And I just started not liking what I see in the mirror because I'm used to having a full face. And for me, I am very conscious about the look that I wanted. And
Mm-hmm.
so I went into this knowing that if I was going to lose the type of weight that I was going to try to lose, that I was going to have to do something. I knew I was going to have to do some plastic surgeries. And I've been open with everyone about that. So everybody knows I had the tummy tuck and the arm lift done back in 2023. June of 2023 is when I had that done. And so now I'm looking at next steps. And so I had next steps in my mind of what I might have to go to next. And so, yeah, it's something. I think it's something that we all need to realize that sometimes it's not exactly. Do you like my face? Oh, thank you. It's just, I'm used to having a full face. And for me now I see, and Keisha, you said it before in your lives, like sometimes when you see these lines right here,
Mm-hmm. I have them.
for me, I'm a night shift nurse, and so for me, I used to have the bags right after I got off my night shifts. Right, when you do 3, 4, or 5 night shifts in a row, you're gonna have a bag or two on your eyes,
Mm-hmm.
right? So I used to just have them then, but now I'm starting to see that they linger, and I think it's because my face is hollowed out more.
Mm-hmm.
Right around my temples is more hollowed out, and so I don't have that fullness that I'm used to.
Mm-hmm.
And so for me, I've looked into a lot of things, and I read and I researched. Y'all know that's what I do. So I know Botox at my age is you shouldn't start Botox late in life. You shouldn't, with the fillers and stuff, it's something you do a little bit earlier in your middle ages. And so I had been studying fat transfers, and I actually had a virtual visit with my plastic surgeon today, and I was telling Kima about that. So I'm not afraid to explore what I need for me.
Yes.
And you just have to have a balance of whether you are being obsessed or if it's something that you knew that you were going to have to look into anyway.
Mm-hmm.
Um, I think as long as we're all clear that you are deserving of
Mm-hmm.
having the look that you want, I think that's the issue too. You got to know
Yes.
that you're deserving of it. In the same way
Yes.
I know for me and my husband, we sacrifice for our boys to go to college. They got their college degrees, they got their homes, they got their little lives, they're doing well. Why wouldn't we deserve to be able to spend some of that money on us? Like, why
Yes.
wouldn't you be able to put yourself first if it's
Yes.
something you truly want? And so and like we've all tried the things. We do the collagen, we do all the things, but for when it's time, for me, I knew the amount of weight I was going to lose. 170 pounds is a whole person.
It is.
Like, if I was going to lose that type of weight, there was no way at my age I was going to be able to escape the loose skin.
Mm-hmm.
And I knew it was going to go beyond just my stomach and my arms. So I knew what I was doing to myself, but my main goal was my health. And
Mm-hmm.
so I got my health back, and so now I'm gonna try to get my look back. And
Mm-hmm.
like I love what my surgeon said. She said, it's not cosmetic surgery for you. You got to look at it like this: it's reconstructive surgery. You are putting
Yes.
yourself back. You lost too much fat out of your face, and you're just replacing. We're sterilizing your fat, and we're putting it back in the pockets where it disappeared from. And we're going to do it tastefully and subtly, but you're just reconstructing yourself back to what you're used to. Um, and that's what, and maybe down the road later I might need a facelift, but I'm
Mm-hmm.
looking at what I can do to adapt to kind of get that look. And I think that's kind of what we need to be open to.
I love that verbiage.
Yeah.
I never thought about it like that.
Yeah. You're reconstructing yourself to the person that you were. If you Some of the losses when people go through this in their 20s, they will have a bounce back. The elasticity is there. And even when we talk about stuff like NAD and glutathione, we talk about all these things that when you're younger, it is at such a higher percentage in your body that's working for
Mm-hmm.
you. But as you hit your 40s and get older, that reduces significantly in your
Yes.
body. So you're not going to have the same elasticity. You're not going to have the same cellular repair.
Mm-hmm.
You're not going to have the same thrive with your cells like you would, because that stuff has reduced below 50%. So it's the same thing. So as you're older, you can still do these things. You can still get your health back and get to a nice weight, but just know that you may have to adapt and adjust some things along the way
Mm-hmm.
to be happy with things. But I'm just saying that y'all, I do want to tell you guys both, while you both are here, how thankful I am for what you are to this community, because
Yeah.
it truly feeds me. I
like to suck up things that are positive and that help me be a better person, whether it's my health, whether it's education, whatever growth, anything that helps me with my personal growth. And the people that you align with and associate yourself with is going to fall within your spirit. And that's just what I believe. That's how I was raised. You are the company you keep. That's what my
Yes.
grandma tell me all the time. You are the company you keep. So, to people don't understand how I can feel this way about some people from social media. You just got to be a part of it. You got to know. You got to know. Just got to know. So I know that you guys on a regular, consistent basis, because I know because it's hard for me to be consistent on social media because I got, with school and everything. But I will say, no matter what, and I know y'all are busy. The fact that y'all are consistent and that it's important to y'all to feed us what we need, I think that's a wonderful thing. And we don't have enough of that in this community. And so I will gravitate to people like you guys all the time. And so I just wish you guys the best. And I want to let you know what you've meant to me and how I enjoy popping in and listening to y'all's live and being in, just being in the corner, just put my little comments in. So you're going to do my hair and everything, y'all.
Thank you so much.
Thank you for saying that, Nurse Rock. I do appreciate it. I do. I love it. I love
We
it. But
love
thank
you,
you for
Rob.
inviting me on. I appreciate y'all. But thanks for tonight. I enjoyed tonight. I really did. It was so
You're
much said
welcome.
about the PAs, and Aaron was great. Just everything was great. It just everything from top to bottom, as my grandma say, from top to bottom. Y'all had it from the top to the bottom. I appreciate y'all, ladies. Y'all have a good night.
You too, my baby.
All right. Bye, y'all.
Baby girl was doing that hair. She was like, "Come on, banana."
Aww. I love
Oh,
Rob.
oh, it's been real. We've had a great live. We have been on here. It's over 2 hours. It's almost 3 hours.
Thank y'all so much. And we got up to 84.1K likes. Thank you guys so much, y'all. Make sure y'all are following Doc Rock. Make sure y'all are following Aaron Sahale, Ask Nurse Kima, Charge Nurse Keisha, and the Health and Hustle podcast, you guys. We will be coming on more often. And again, we are seeking out other providers who are also will dedicate some time to the Health and Hustle podcast and our viewers to get you guys the clinical support that you need. So that is very important to us. And like Rock was saying, yeah, it feeds us. It's so rewarding to me. It's just so rewarding to give people what they need, and a lot of that is what I need. You know what I'm saying? Like, I identify in so many of you, and it just feeds my spirit, and it's so easy for me. I swear, if y'all could see what I look like 15 minutes before this live, honey, a mess. I worked last night. I had to go to get therapy on my shoulder at 11, y'all. I was in Home Goods at 1:30 p.m. Okay, hadn't went to bed. Took me a nap, y'all, and then I was here on time and ready. Okay, you can't y'all don't know what this head look like underneath this wig. Oh God, honey, you wouldn't recognize me. Oh gosh, Jesus. But I love y'all. I really do love this community. I do want like positive vibes, good vibes, good intentions, like-minded, just no confusion, because it's tough enough. It's tough enough. I don't want to come on here to my social media family and feel like I gotta be someone who I am not. I want to be authentically and genuinely who I am, and I want to give what needs to be given. You know what I'm saying? And I love the fact that you all come with the same mindset. Like, we get each other. So Thank you guys so much. So much.
There's enough going on in the world that we have no control over at this point. So what we can control is the peace, what we allow in our lives. So yes, Rock said it best. Align yourself with like-minded individuals because you are definitely the company that you keep. That's okay.
Yeah. And if it don't feel right, it ain't right. If it don't feel right, it ain't right. If you gotta question it, something, your intuition and your discernment is yours alone. Okay, so listen to it. Because we do.
What a sign,
Now,
man.
now, before we go, I would love for us to get up to 100K likes. So we're already at 88.4K likes. While we are getting up to that point, again, if you guys are not following the Health and Hustle podcast, make sure you guys are following the Health and Hustle podcast, y'all. We have recorded our 4th episode. Now, I know y'all might think our little episodes come far and in between. We post 1 episode a month because, again, we are full-time nurses in the community. We are full-time content creators. We both are in committed relationships. We both have children, spoiled children at that. Okay, so
Yes. Jesus.
but we definitely do make the time to make sure Health and Hustle is giving the community something that is useful, something that is needed. We hear y'all, and we want to again continue to give you guys the information that y'all need. This next podcast that's coming out is centered around mental health, primarily because mental health in America right now is just so it just needs we need help collectively as Americans. We need help. I've been seeing in the emergency room and outpatient a lot of anxiety, depression, bipolar disorder. We've been seeing a lot of SI cases. Since the GLP-1 community is so huge, we've been seeing a lot of BDD. A lot of people mishandling GLP-1 meds and all of the things, y'all. It is so sad. It is so sad, y'all. We just feel like it's something that we need to talk about. We are going to be giving y'all identifiers so that you can identify when you or someone you love is experiencing certain things. Body dysmorphic disorder, baby. Body dysmorphic disorder. So we are trying to educate the community on what the identifiers are, what type of treatment you can possibly look into, the type of doctors you need to look into, the type of medications that can be prescribed, behavioral therapy, therapists that you can go to. We give y'all all that information. And not only do we talk and educate about those situations, we're also giving you numbers that you can call, websites that you can go to. We are very, very solution driven here at the Health and Hustle podcast. So we're not just on here talking, we're giving resources as well. Y'all know Kima is a certified case manager. So she has a certification in that. And so, honey, we're going to get y'all what y'all need. Okay. 100,000, y'all. Thank you. Let me take a picture so we can make sure we post it. And then it was one other thing I wanted to say. Where is the best place to get what, baby? Oh, Lipo C?
KG, she is so crazy. No, KG, she talking about the Atlanta thing in June at the ATL Zoo.
Oh, okay. Okay. So, as far as speaking of dates, I'm so glad you brought that up. Ask Nurse Kima, myself, and Sade are hosting a Galentine's event. You guys here in Houston, y'all. The box office has already closed for that, so we already have our guests who have committed. But we want to let you guys know that it will be something that we are attempting to do annually, and not just in Houston, Texas. I believe it may be in Atlanta next year. But as far as the Health and Hustle podcast. Kimmy, you want to talk to them about what we have going on March 1st in Atlanta?
Yes, so I posted a flyer on my page on the stories. I'll repost it on my page. But March the 1st, we will be over at the Stonecrest Mall. It's on the inside of the mall. So we're not going to be outside. We're going to be on the inside of the mall. We are participating in a health and wellness fair that is being put on by my chapter, Top Power Mega chapter of Alpha Kappa Alpha Sorority Incorporated. So it's from 11 to 3 on March the 1st. Health and Hustle will be in the building. So make sure y'all come by, stop by, and check us out. Okay.
Come on through, honey. Come on through. Okay. We're gonna be providing to the community wellness information, you guys. Just typical like annual wellness checks that you need to be getting, the type of different specialties that you can be looking into, different labs and stuff like that. So that's what we will be educating the community on at the Health and Wellness Fair. So I look forward to seeing all of you in that area at that time. And then we will also be back in Houston at another health event in April. So we will talk to you guys about that as well. What mall is it again, Kima?
Stonecrest Mall in the new established Stonecrest, Georgia. Okay. In DeKalb County.
Okay, sister, do you have anything else for the peoples? 'Cause I think we good. We good. Thank you guys so much for attending the live. We will definitely announce when we will be having our next live. Aaron has committed to coming on and talking about different topics with us, y'all. So make sure y'all send us a cute little DM, a cute little DM or a cute little email, so that we know what it is that you guys want to talk about. And also, if there is a specific question that you want to be answered, send us the question. We'll even make a list of questions to make sure at the very least, if your question is not answered in the conversation, because we do miss a lot of questions in the conversation, just getting caught up in the education of it all. But send us the questions you specifically want to be asked, and we'll make sure we'll put it on the list as well.
Somebody, desirable nurse, is asking where at in the mall. Okay, so I've only been to Stonecrest a few times, and it's been a long time ago. But I know they're gonna send us instructions how to navigate through the mall, where to go. So I'll put that, do a video with the flyer and the directions. So I'll be able to tell you specifically which entrance to come in, so you'll know how to find us.
Very good. Okay, Nurse Kim, I love you, girl. This was amazing. I feel so good. I made it, honey. I made it.
Yeah, you did, and that's time to.
And you worked today as well.
I did.
Lord have mercy.
Yeah, look.
Lord have
like mercy. You say 15 minutes before, baby, I was not. This was. Baby, me and the PJs was locked in today. We were locked in.
Oh gosh. Make sure you guys are following the Health and Hustle podcast, y'all. Go watch our podcast over there on YouTube, honey, and look forward to seeing that 4th episode on mental health. You guys, this was a great live. I appreciate you guys. Hey Ronnie, hey friend, hey sister, Vaughn, my love. Okay, Kima.
All right.
We'll talk to you guys. Y'all have a good night. Bye.